right, today are we all good?
Yeah, we're good.
Oh, recording in progress. Okay. I have a series of webinars that I give, and I'm going to be adding to that a lot here. One of the things I've talked about several times before is BPH, or enlarged prostate. So that's what we're going to talk about today. There'll be other topics forthcoming in my series, but we're going to talk about enlarged prostate, which is something near and dear to my heart, because as I get older here, I'm 55, I'm right in the wheelhouse of what most of my patients are experiencing. So let's kind of dive into it. This is a fixed slide set, and so you're going to sometimes see me veer off the slide set, or maybe say this is a little bit different how I do it, etc. So let's get started with this. Okay. I don't know if this was part of the housekeeping items, but I guess we're not supposed to record this, just like an NFL game. This is me. I have a Chevy Chase location, and hopefully a lot of you are my patients. Maybe some of you are my old partner's patients. We have a Chevy Chase office. I have a new physician now, Andrew Tobin, and I have a great nurse practitioner, Ndidi Okanu. So a lot of good things have happened lately. What we're going to go over is what's a prostate, what does it do, what problems does it cause, because it causes lots of trouble, and then specifically the trouble of it growing. That's what happens as you get older. That's what BPH means. And so we'll talk about an overview of it, who gets it, how common is it, very common, and then what are all the different things that we do about it. So let's dive into what is a prostate. So this is a basic picture of the human anatomy. So and you're going to find throughout this talk that what I'm going to do is I'm going to basically, treat this like it's a telemedicine visit. I'm going to use the same analogies that I use for all of my patients in the office. The prostate is a gland. What's a gland? It means it's an organ in your body that makes something. It makes prostatic fluid. We don't really totally know what that's for, but I view the prostate as more of a plumbing piece, a junction valve. It's very incredible that men can use the same tube, the urethra here, to urinate through and also to ejaculate through. So, and what allows that to happen is the prostate. So the structures that make semen plug in there, and then you urinate through the middle of it. So it's kind of a weird junction valve. It's not that important in making things, but it's a junction valve. And so that's important. Problem with it is that it grows as you get older. And as you can see here, that if you urinate through it and it starts crowding things out, it makes it harder to urinate. They say that it starts growing in the early 20s, but in reality, where a man's going to start coming in saying, hey, I'm starting to have problems is really in their late 40s. 50 is the sweet spot for when people start to say, I'm really noticing there's a change to my urination. And so the prostate, I always tell people, is probably the best example of that we as human men are not supposed to live as long as we do, because it just starts causing trouble once you get to a certain age. So this is listing the different troubles that there are. And each one of these are really separate topics altogether. And when patients come in, they usually combine these topics. They're usually mixing and matching them together. And I usually make sure we try to segregate them so that people understand. Let's talk about your enlarged prostate trouble. Let's talk about PSA, or prostate cancer. Prostatitis is worth mentioning here. It's kind of a catch-all phrase for someone with urinary symptoms that oftentimes usually doesn't have an infection. We over-treat that as an infection. We call it chronic pelvic pain. But anyway, the idea is different problems. They all start happening as you get older. They all have to do with the prostate. So now let's focus on just enlarged prostate. And patients will come in and say, I had a rectal exam with my internist and I have an enlarged prostate. Well, that's not really what we're going to refer to as urologists as BPH, which stands for benign, no cancer, prostatic hyperplasia, which just means it's growing on. I usually don't mention if a prostate is big or small, et cetera, unless it's important to our conversation. But patients usually worry that when an internist tells them that their prostate's enlarged, it means it might be cancerous, etc. BPH is a process that happens in every man, and in some people, it causes trouble with urination. And we call that's what we're going to call BPH, the symptoms that come from having a prostate that grows on you as you get older. And these are some good take-home points. I like this slide. And we're going to talk later about the progression of BPH. It always gets worse, and what it starts with, and the office visits that I do for each phase. So number one most important thing is that BPH or enlarged prostate is not prostate cancer. It really has nothing to do with prostate cancer. It doesn't cause prostate cancer. And I really kind of don't agree with this statement, BPH symptoms are similar to those of cancer. What I teach my patients is that cancer, unless it's in its very rare end stage form, doesn't really have any symptoms. So we're going to talk about this in the progression, but one of the most common things I'll see is a patient who's just starting to notice a change, and they just want to be reassured that that change isn't from cancer. So that's an important point. You can have prostate cancer and you can have enlarged prostate tissue, but just realize these are separate issues. And PSA, which I have a great talk on my website, which is dcurology.net, it's one of my webinars, and it's confusing. PSA does get elevated from enlarged prostate. In fact, that's the most common reason for it to be elevated. So I won't dive in too much about PSA today. That's a separate talk. Just know that that is a real common reason to have an elevated PSA. It's the most common reason to have a barely elevated PSA is that your prostate's bigger. Bigger prostate, more PSA. And this is just an obvious slide. Everyone can imagine that if you're, the sink, and I'm going to go back to using the analogy of a bathroom sink. Everyone's got a bathroom sink that starts to drain slowly. If you're married, it definitely drains slowly. Hair goes down in there. But as that gets slowly clogged, the sink drains less and less. And that's really what this is. The bladder is the sink. The prostate is the pipe that gets clogged. And we'll talk about how that relates and how this analogy relates to how I treat people and how I advise them to do it. But the key here is that you can have a huge prostate and it just doesn't block you. It's like a donut or a bagel. You can have a massive donut or a bagel, but if the hole isn't small, then it's not going to block you. So prostate size doesn't always correlate at all with how badly you're obstructed. Plenty of them with small prostates are obstructed. That's an important point. And this slide is anyone that's on here that has this issue, any man knows about these symptoms. And so I don't need to go into them in great detail other than to say the one that really always gets people to ask to be treated almost always is getting up at night. Nobody usually asks to be treated for having a weak urine flow. It can progress to the point of not being able to urinate, but it's the getting up at night that's usually the thing that drives people the most to ask for treatment. This one just says it's really common. And this one basically says that everyone gets this problem. So not everyone is severely affected. Not everyone is going to be bothered to the degree that they want to be treated. But basically, eventually, everyone has this problem. You go to a nursing home or you go to a retirement community, you can count on the fact that the men are in the gym talking about their prostates. So how do we diagnose it? Well, how I'm going to diagnose that you have a problem with an enlarged prostate is just really by talking to you. Again, the rectal exam is not so important in this. If it's big or small, it's based on how bothered you are. There are a lot of groups that will do lots and lots of testing here. I usually don't. I don't really need to. If you tell me your urine flow is slow, I don't need to really test it. But I do always check to see how well you empty your bladder. We'll get into why that's so important. And I do always have you fill out this survey, which is called an IPSS survey, because it's extremely powerful. It tells me in 2 seconds who's there because they're bothered and want to be treated, who's there to be reassured, who's there that just wants to know what the next steps are. So this survey, which they don't have a slide up here, but anyone that's been in my office has filled it out. It's very powerful. It tells me in 2 seconds, what are we talking about here? And so now let's dive into treatment options. But before we dive into treatment options, this slide is, I'm going to spend a little time on this slide. So, and again, how I would present this is a little bit different than it's presented here. I present this problem, which is not cancer. This is just an annoyance. There are certain circumstances where it's more than an annoyance. I saw a patient today who had kidney failure and they couldn't empty their bladder. Their bladder had been stretched out and needs some work there. And that's a dangerous situation. So that's going to be a situation that I'm going to tell that patient they have to be treated. Maybe if people keep getting infections or stones, there's going to be times where I tell the patient, you need to do something about this. This is a problem. But normally, I'm going to leave whether a patient is treated in the patient's hands. And that's strange to some people. They want the doctor to tell them what to do. But in reality, mostly this should be driven by the patient with regards how far down the progression of treatments do they want to go. So let's talk about the different stages, and some of them are represented here. The first stage, which is not here, is reassurance. If a person comes in, they're almost 50, I tell by their survey they don't have severe symptoms. I know they're there to largely be told they don't have prostate cancer. And when they get screened, they're shown that they don't have it, and that's all they're looking for, is to know that they're okay. So I'm going to call that stage 1 of this process. Stage 2 of this process would be under this behavior modification. That's where the patient is starting to get annoyed. I'm at stage 2. I'm annoyed. I have to get up here and there, but I am not bothered to the degree that I would actually dive into being treated for this. I know what it is. I'm not worried. I talk to people about it all day. And it is true. I work out a lot. Those of you who have seen me might know that I do that. I try to hydrate a lot. And I know I'm going to pay for that if I'm hydrating all night long. If I'm drinking at night, I know I'll be up all night. So there are people that will say, I don't want to be treated and I won't drink after dinner. But mostly my message is, you come back and see me if it gets to the point that you want to be treated. And I'll probably get there one day, but that's really what watchful waiting means. Kegel and bladder retraining are things that probably are best reserved for women who leak urine and other things. All that is saying, and we've all been through this, if you've been in the car, if you've ever been in the New Jersey Turnpike, it's long distance between exits. If you have to urinate badly, squeezing it like you want to try not to urinate can sometimes get your bladder to calm down. That's really all that is, but none of that is really fixing it. Mostly behavior modification means you're just going to live with it and deal with it if it gets worse. Now, here's where I very much differ with this slide, and that is, if a patient finally says, I'm ready to be treated, in my practice, that always means medications first. That doesn't mean you have to stay on them forever. There's patients that will say, I really don't want to have medication. That's not a good solution for me long-term. I'm not on any other medications. They might consider a procedure, but I'm still going to expose them to that. I'm still going to say, I want to see if it works. If medicine works, it tends to predict success with a treatment. But for me, the next step, so we talked about first stage is reassurance. Second stage is live with it until you're bothered enough to ask me for help. And then the next stage is medications. And we'll talk about those in a minute. We'll come back to the treatments, but I'll just talk you through the rest of the progression. If a patient is on a medication, and some of you might be my old partner's patients, and he did this differently than me. If a patient starts on a medication because he is bothered and it doesn't really help, which happens all the time, or it worked and now the bagel has gotten even more problematic, the sink has gotten even more clogged, well, he'll come back and say, it's not working for me anymore. It's at that point where I'm going to consider the next step, and I'm going to offer the next step to patients. And some patients will say, I'm ready to take the next step. And some patients are fearful of any procedure whatsoever, which is one of the reasons we're having this talk, to get rid of fear of the unknown. And in that case, I consider adding more medicines or taking more of the same medicine largely as saying, I'm not willing to do anything else as the next step. Those added medications or doubling medications are not likely to help, But at the end of the day, if there's nothing else to try, I talked to a patient about this yesterday, you may as well try those medicines. The analogy of the sink comes in here. The person that's asking for medicine is the person that's ready to put Drano in their sink. If they come back and they say the Drano is not working, usually I'm going to say, I'm a fixer-upper myself, I'm going to go to Home Depot and get some kind of snake or something like that. That's sort of the next step in procedures. But if I'm not willing to do that, I guess I'm going to pour the whole bottle of Drano in, which probably won't be the long-term solution, or add a second brand of Drano. So I don't have a lot of patients that are on two double dose pills and a second medicine and a third, because most of my patients will learn about this on my website, see that an office procedure, that's what the next step is the logical next thing to try. And that's why I do a lot of them. That's why I'm giving a talk here today. Surgical procedures we'll get into last, but in my practice, that tends to be for those patients that are hurting themselves, need more aggressive therapy, or have failed an office procedure. So let's talk about what office procedures are. This slide is in here, and I'm ready to talk about it. It gives a sense saying, don't use herbal remedies, don't use saw palmetto or things like that. I wouldn't say that as a warning at all, but it's worth pointing out. A lot of patients that are just in that phase where they're not looking to be treated, but they will take an alternative medicine. That's fine with me. The key with alternative medicines is, and I tell patients this a lot, drug companies are, trust me, they're not stupid. They are extremely powerful. They are not organizations that are not aware of the things that are considered alternative medication. They know all about those, and trust me, they've tested them all to see if they work better than sugar pill. And if they did, trust me, it would be on the market. So the issue is that there's not much evidence behind any of them. It's not to say there hasn't been attempts at evidence. There's been a lot of attempts at evidence. Saw palmetto is the best example of that, where there was one study that at first showed it might work, and then many studies that show it didn't. So that's the idea here. If patients want to try it, it's fine. But when they're ready to really be treated, we usually put them on a medicine that has undergone testing, FDA approval, so we know it works better than sugar pill. That's what I'd say about alternative medicines. And so these slides are just individual talking about the stages that we just went through. This is the stage of, I'll wait and see if it gets worse before I get treated. And that's absolutely fine. This is the stage of saying, I'm ready to be treated. And what you would be treated with is a class of medications called alpha blockers. And what they do, and this is really the mainstay of what urologists do these days. What alpha blockers do really are they relaxing the base of your bladder and some of the muscle in your prostate. It's try to relax it so it'll open up a little more and let the urine flow out more freely. If the urine flows out more freely, then what will happen is you'll empty your bladder more. If you empty your bladder more, there's more time between needing to urinate. If you empty your bladder more freely, your bladder, which is a muscle, won't be so irritable and fatigued. That's where the frequent urination comes from. Examples of alpha blockers would be, in my practice, the trade names would be uroxetrol, that's known as alfuzacin. More common and has been Flomax, that is called tamsulosin. There had been a recent one that was not generic. I don't use it much because it has more side effects with ejaculation. That's called Rapaflo or Silicodin. So in my practice, most patients will go on alfuzacin. It has the fewest, least effect on ejaculation. There are some, recently we've been made aware of some drug interactions, so we have to look out for that. And Flomax is probably the most common thing. So these are alpha blockers. This is the mainstay. The side effects are not terrible. And maybe it's you get a little dizzy or fatigued. And if that happens, we switch you and move on from there. Again, if a patient fails this, they get side effects, it's not working well, etc. I'm going to say, look, the writing's on the wall. You can always live with it. There's nothing wrong with living with it. But if the first pill of alpha blocker isn't working, you may get a little bit better results with 2 of them or with more medication. But that's when I'm going to introduce the notion to at least research the easy office procedures that I'm about to describe. The second medicine that we can add is called a 5-alpha reductase inhibitor. Those were the first medicines out. That was called Proscar. That was a blockbuster for the company Merck, until the makers of an alpha blocker did a head-to-head comparison and showed that actually Proscar didn't work any better than sugar pill. And now it's marketed as Propecia for hair growth. There's another one called Avodart. So this is called finasteride or dutasteride. These medicines take 3 to 6 months to have effect. They can make it hard to interpret your PSA. If a patient's not willing to do anything else, or if they have a huge prostate, these work a little better on huge prostate, then these will be offered and added. And again, if a patient just says, I don't want any procedures, then this is what we'll do. We'll add more medications. What people get scared of with these is this one has a potential for erectile dysfunction and gynecomastia or breast enlargement or sexual side effects. So a lot of people try to shy away from this, and so do I. And so now you're a patient that says, I've tried medicine, I either have side effects, it doesn't work, I've decided on my own whether I want to take 2 medicines or maximum medicines. But again, the next step up in my treatment algorithm is not aggressive procedures. It's what I call office procedures. I'm going to talk about this as one office procedure, but what I consider, and this is the world according to me, but what I consider office procedures and what is ubiquitous of office procedures is that they are designed to be done in the office. They are designed to be easy. They are designed to basically offer about a 78 or 80% success rate, which is not 95%. So they must be simple with few side effects and risks, okay? To me, that's the reason, that's what you're looking for in an office procedure. And so I'll list the ones that I've been exposed to. Some are on the market still, some are not on the market. And I'll actually start with the one that I did for 15 years. That's called the tuna procedure. And I still do that on some occasions. The tuna procedure is basically looking into the donut or bagel hole and using needles that come out the side of the scope to vibrate and create heat. So it's really heat therapy. It's heating tissue. It's not cutting anything. And you're looking for the tissue to wither and then the hole to retract open. And that was called a tuna, transurethral needle ablation. That evolved into the next heat treatment, which I call tuna 2.0 or 3.0, and that's called a resume. Resume is what I do now. And what it is also heat out of a needle, but it's like the iron that has, when you press that button, it goes, whoosh, and it happens quickly. And it kind of spreads out. So there's a real theoretical advantage to water droplets coming out because the steam will spread out in the prostate, maybe treat more of the prostate, and it's much, much faster. We do several treatments at one time. The tuna was 2 minutes and 20 seconds, and the resume, for example, for the same treatment is 9 seconds. So there's a lot going for the resume. I had a previous talk that talked about this and talked about tuna, talked about resume, and I was basically saying I was sticking with the tuna. At that time, my impression was that there was more pain involved with the resume, even though it was shorter. And my impression was that more people had a harder time urinating when I took the catheter out. We have a catheter for just a few days. What I did is I took another look at the resume. I think I've perfected my own way to numb people. I've actually found that to be, I might write that up. I actually find that to be extremely efficacious now. It works. It doesn't really hurt much. I think my patients, they feel a little something, but it's definitely not worse than the tuna as I used to do it. And also, it's a more intense therapy, but the reality is I'm starting to see all these patients back now. I've done many of these, and I'm starting to get the sense that actually the success rate is a bit higher. I think it's more intense than the tuna. I think it's more intense, and therefore it's no surprise that it's a little harder to urinate when you first get the catheter out. I've had to learn how to counsel my patients and know who's going to be at more risk of having trouble than not, support them. And since I have had more experience, I have found it to be a very, very smooth transition to the resume. And the fact that it's so quick and simple is something where now I've made that transition now that I have the experience. Other things you might read about that are not around anymore that are heat treatments or microwave treatments, but that's that category of those treatments. Very few side effects and risks of a Rezum, but the one thing that I've told tuna patients and Rezum patients is that it can cause you to have less semen afterwards. About 20% of people will have that. Frankly, since I don't consider it first line and I already have people on medicine and I don't really talk people into it or give a sales pitch, I find that most patients with enlarged prostate already have very little semen. They don't usually have a lot of semen already, and it's just not an issue in my practice usually that people will have less semen. Now, the one that everyone's heard about, the office procedure that everyone has heard about, is called the UroLift. This is the generic name, prostatic urethral lift. And its main claim to fame is that it generally doesn't affect the semen volume. But I find there to be some downsides to the UroLift, and it's why I haven't adopted it. I don't really want there to be any more of a risk than a patient that has to have a catheter an extra day or an occasional UTI, that kind of thing. That's what I'm looking for in an office procedure. The UroLift can have more dire consequences. They can have pelvic bleeding that you have to be in the hospital for. I'm not looking to have that as an office procedure. And it's putting permanent foreign bodies in your prostate. It's a suture that you fire through it and it pulls it open. And that's just sort of against a lot of urologic principles that I follow. I've seen a lot of patients where they have some of the side effects you see here, pelvic pain and infections where we have to shave out those things. And it's just more than I'm bargaining for myself. It's also not one size fits all. You can't do it on all the anatomies like you can with the Rezum. And so I've decided to just stick with one, and that's the Rezum. If I was doing UroLift, I'd probably look at modifications and I'd try to make it the best that it could be. And if you were to see a urologist doing UroLift, there's nothing wrong with it. It's just if I wanted to choose one or the other to get really good at, and I found that there were more advantages, and it's more a universal procedure of the Rezum. Plus, I was extremely familiar with the technology, having done over 1,000 tuna procedures. I would say with all of those procedures, though, we're looking for about a 78 to 80% success rate. I feel as if I'm seeing a bit more of like an 85% or more success rate with the Rezum. You have to pick and choose who you do it on. It's not for the person that just has a terrible bladder or has waited really long. And it is best applied, therefore, when someone has failed that first alpha blocker, not necessarily after then they add a second and a third and a fourth, and now their bladder is all stretched out. So you got to choose patients wisely and counsel them so that they don't miss the good window for doing an office procedure. Now, if office procedures fail, then the next step, because the office procedures, particularly the Rezum, doesn't burn any bridges. If it doesn't work, that means it wasn't enough obstruction relief usually. And maybe we have to then move on to something that takes you to the operating room. So I'm going to call the remainder of what the treatments I described as office procedures. I'm sorry, as operating room procedures. Okay, operating room procedures. Now, this is another one that's heavily marketed called the green light laser. So the two things that patients come in asking for typically are UroLift, because it's very, very marketed. They have TV commercials. And green light laser, because it's got a lot of tempting marketing. I don't do many green light lasers, and it's for the following reasons. I know that it's a very common procedure that people do, and it's generally very common when urology groups tend to have their own surgery centers. One of the advantages of a green light laser is that it can be done in a surgery center as an outpatient. I do a lot of TURPs. We're about to talk about that as an outpatient. You're going to call it a roto-rooter job. But the reason I shy away from the laser procedure is that I do a lot of office procedures. I find that that's the true minimally invasive procedure. Someone keeps texting me, so we'll turn that off. That's the true minimally invasive procedure, our office procedures. The laser procedure has the same risks as the more aggressive procedures. It still carries with it a risk of urinary incontinence. It's only about 1%, but it's the same as the others. But it does have a much higher risk of scarring and narrowing, and it doesn't tend to be, in my hands, as complete as that. So if I have someone where I'm going to take them to an operating room, and they're going to go through the trouble of getting cleared for anesthesia and going, in a hospital and undergoing some of the risks that you see here, which are the same as all of them, I'm usually going to do what's called a TURP. Okay, nothing wrong with the green light, but that's the reason I do that. I don't consider the green light as the true minimally invasive procedure that it's marketed to be. I consider the Resume as the minimally invasive procedure in my practice. The TURP has been around forever. TURP stands for transurethral resection of the prostate. It's like a rotor-rooter job. So the laser is going to look in and heat the tissue at such a high degree that it vaporizes and opens up a channel. The TURP is going to shave it out with an instrument that I liken to sort of a fancy cheese slicer, but it's electronic, and carve out a nice opening in the middle of the prostate, make that vagal hole very big. The operating room procedures all generally take away the ability to shoot semen. So whereas it's a small, tiny risk with office procedures, the operating room procedures, you need to expect that, basically. And, the side effects here are just things to know that I counsel my patients. But the TURP used to be the most common operation in America before other things existed. Before medicines existed, it was almost a rite of passage in men. Almost every man got a TURP. It's something that a lot of residents aren't learning to do a lot of these days, because that's another reason why people shift over to the laser, because it's got a very low learning curve. And the TURP is actually a relatively hard operation to do well. So you're going to find that my age and higher are the ones that are generally going to be able to do a good TURP, because we really learned how to do them. It's kind of an art to do them, but this is my mainstay operating room procedure. The laser, by the way, we call it the laser procedure, the green light laser. Of course, there's several other lasers as well. They're just not marketed. There's something called a Revelix laser. There's a lot of laser energy that can do that, but the green light laser is really the champion of that arena. It's not that I don't do them. If patients ask me to do them, again, I generally would do a TURP if we're making it to the operating room. And then this is where I'm probably going to go off the slide the most. The final step in this progression is not really prostatectomy or removal of your prostate. That's going to be for cancer. The final step tends to be a TURP in my hands, but I'm going to do something called a robotic simple prostatectomy for those with a very large prostate. So I always say to patients, look, if you have problems and you need this done to your prostate, but if you have a very big prostate, you get a different menu. That's what I call it. You don't get the regular menu. You get a menu that's very limited. I was just talking to someone today about this same thing, and I call that like the Mother's Day brunch menu. There's only like 2 or 3 entrees on there, and that's it. They are a simple prostatectomy. That's what this slide's referring to. So it's talking about an incision, etc. There was a picture of a scalpel before. And so if you have a very big prostate, it's very similar to one of those excellent navel oranges you might buy in a nice store, where it's got a thick skin and the pulp is really easy to kind of pull out of there. Well, it's the pulp part that grows on you as you get older, and it's that has to be removed. If it's a very big prostate, it would take too long and be too bloody to shave it all out or even attempt to laser it. So we have to do an operation that can get in between the pulp and the peel and basically just root it out, and so that you're pulling out basically a tumor, a big benign tumor, and you're wide open. So it used to be done through an incision. I don't think I've done that in well over 10 years. I don't think hardly anyone does that anymore. That has been replaced with what's called robotic surgery, which is something I specialize in. And so it's in my skill set to do that same task with robotic surgery, which is more minimally invasive. That's actually much harder to do than a cancer operation with robotic surgery. So there's not usually many people in town that are going to be adept at doing it, but that's what I'm going to offer on the menu, because that's the chef's specialty in this practice. There's another procedure that's done through the penis. It's not done through little incisions here, and that's called a HOLEP. That's a laser procedure. That's a fine procedure. Again, that's a very specialized skill set. You're not going to find someone who does a HOLEP. That's what that's called, holmium laser enucleation of the prostate, that does a robotic simple prostate. You're going to find someone that does, this well or this well, And I don't really have a great opinion either way. There's every meeting has everyone debating what's better. If you find a urologist that's going to solve the problem with a holdup and they're good at it, that's certainly with my blessing. But certainly I don't feel any pressure to do that because there's, as I said, there's pros and cons, but both are going to leave you wide open and they're relatively safe. And then the last thing that people will very much read about on the internet is marketed is something that you would do if you did not have these skill sets and you didn't want to refer a patient to someone who did. And that's a machine that's out now called aquablation. Aquablation, if anyone's seen that on the internet. That's something I very much looked into. It was minimally invasive. I tend to look into new technologies, and it's in essence a water pick, if anyone knows what that is, for their teeth. It's a very hard shot of water that goes like this and just blasts the tissue open. The problem is it bleeds and bleeds and bleeds. And so there's a fair amount of risk of having to go back emergently to the operating room and stop the bleeding and that's just something you don't see with to the same degree with the two other things I mentioned. So you're not really going to find someone that knows how to do a robotic simple prostatectomy or a holdup that ever would offer the aquablation because the bleeding risk is too high. And that's why I generally discourage my patients from thinking about that. So that's what you're going to do for big prostates. Otherwise, you're going to follow that progression in my practice that we've talked about. I guess this is just to show, insurance generally always covers all of the things that I've just described. But good news is most BPH medications are now generic. So they certainly would rather have you fixed than not fixed and have trouble. And so again, this is just just again, the different things we've talked about. It's really just a review slide here. And I think that's been a pretty good, summary of the problem and summary of the problem according to me and the world according to me. This slide is here. I would just invite anybody. We're going to try to answer some questions. Time is somewhat limited, but most of you all have been patients here before. Certainly, we could have a much more involved one-on-one conversation with regards to this. I'm always available with telemedicine, and dcurology.net is my website, and certainly we can talk more there. But I think this would be a good time maybe to take some questions.